uh, long axis. These are obviously four-chamber view, long axis views of the heart. And we have the right ventricle, left ventricle, and both the atria in view here. So this is the septum, the muscle between the two ventricles. And 1 week after this patient suffered a myocardial infarction or a heart attack, uh, to determine what the status of the tissue is post a heart attack, you can do this type of exam, which is you inject contrast, gadolinium DTPA, it's called, and it will light up areas of myocardium that have undergone a metabolic challenge, let's put it that way. And so at the 1 week time point, we see a couple of features here. One is bright signal right along the apex, all the way around here and up the septum on the epicardial layer. Let's put this. So this is the epicardium, or the outside layer of the heart away from the chamber. There's a very dark signal in the interior of that, and that's either normal myocardium or if it's even darker, it could be an area in which there is essentially blood clots on a very microscopic scale. So it's like hemodynamically stressed in that nothing can flow in there, right? It's completely blocked up. And obviously there's some middle of the road contrast here in the septum. So if we wait 4 months and bring this patient back, and in the interim, obviously this patient should be wearing some kind of ECG, ideally a defibrillator, because having this much of your myocardium under this much stress post-MI is pretty dangerous. This is can be a nidus for generating ventricular arrhythmia, which will go on to be, from ventricular tachycardia to ventricular fibrillation and then sudden death. 4 months after this, we come back and do this exact same procedure. We inject gadolinium DTPA, and then we make an image. And that contrast has essentially gone into tissue that's infarcted, and it gets stuck there. And so now we can see the extent of the infarct. It looks quite different, right, than it did back here. The wall has sort of consolidated that infarct and it's become thinner. There's now either normal myocardium on the endocardial side, or again, this can be hemodynamically challenged tissue that still really isn't allowing any contrast to go in there. And this is the stable configuration now of this tissue, and is going to look like this for a long time. What's probably going to happen is the tissue will get thinner and it'll get stiffer, and then a year from now, it can possibly start to balloon out as a kind of aneurysmal thing. So you can plan what you should do for this patient. For instance, if there was a tiny little solid infarct right here, and that was the extent of the damage, and it was quite small, you probably may not need a defibrillator in that patient. In this patient, because there is such a large space of myocardium that is essentially out of commission, will cause electrical abnormalities, you probably want a defibrillator in this patient. So we talked about T1 and T2 time constants. And the question is, if you know the underlying T1 and T2 in a tissue, is that at all useful? Originally, nuclear magnetic resonance, when it was proposed as something to detect cancer, it was thought that what we would do is we would localize tissue and measure the T1 value and the T2 value, and they would be very specific for different types of cancer. That turned out not to be the case. They are not specific. However, longer T2 and longer T1 often is associated with, say, a lesion like a tumor. So it went out of fashion for about 30 years to even measure these time constants. You just created images as quickly as you can with the best image quality that you can. and the T1 and the T2 participate in creating contrast, but you didn't really invert the signal to get the values. Remember how we get a signal that's proportional to T2 is we perform a 180-degree pulse usually, and we get a spin echo whose height is proportional to the T2 decay that's occurred between the 90 and that time. Question, are those useful? Some tissues have longer T2 values, others have short T2 values. And so the contrast generated by the T2 is traditionally what we've used to differentiate different types of tissue. So here's a slide. I think we looked at this briefly, but we didn't really look at it in detail. This is acute imaging in the red box, and this is chronic imaging in the blue box of the same patient. And so this is right after the person is presented with a heart attack. So they've had EKG abnormalities, and they're obviously being imaged to determine what condition their heart is in. This LGE image is called late gadolinium enhancement, and a infarct looks like this on LGE imaging. The contrast sticks there, and you get a very bright signal. So we see in this patient, immediately post the heart attack, there is no bright signal in their myocardium. So at this point, there does not seem to be an infarct, or at least one that can be recorded using late gadolinium enhancement. However, in this same patient, when you look at a very heavily T2 weighted image, you can see that there's this differential contrast in the myocardium in that there's a huge chunk of tissue here that has a much longer T2. That is, we're seeing a brighter signal at a later time. So we get this increased T2 or brightness. The question is, what is this from? Well, this tissue has received an insult due to the loss of blood flow, and the cells have undergone some kind of transformation metabolically, and they're quite stressed. And so what happens under those conditions is you get inflammation. And so the cells puff up, they retain fluid, the tissue itself retains fluid, you get essentially a different type of immune response and cells coming into the area. Just in the same way, if you challenge tissue by burning it, if you put heat on it to burn it, the tissue will swell and puff up. This is direct imaging of that swelling. And so when the tissue swells up, it becomes more watery, the T2 gets longer, you see this bright signal. And so we know, even though this image did not produce any kind of abnormality, we know this patient has undergone a pretty significant challenge in that the large chunk of myocardium that has extended T2. When we wait, it'll be in the caption here following risk area. I don't know what the time delay is between this and this. I don't see it in here, but it's some say 4 weeks. And we make 2 more images, one late gadolinium enhancement and one T2. They change quite dramatically, right, after 4 weeks, in that we have this late contrast on the epicardium and on the endocardium, all the way around here. There's a very dark section of tissue here, and what's going on there is that gadolinium just did not get into that tissue, right, at all. So it's basically blocked off entirely. It's sort of like it's like a hemorrhage in the tissue. And then when you have a hemorrhage and the blood congeals and then forms hemosiderin and all of stuff, and then the tissue locks down as a long-term hemorrhage. This is what it looks like. And so we can see that arc over possibly half of the heart. The extended or the lengthened T2 has now consolidated, and it is much broader than it was in the acute phase. Now we can see a T2 challenge all the way around for half of the heart. And again, this dark stripe is confirming that the basically it's like a hemorrhagic uh, piece of tissue that just doesn't have any blood flow in it. So this is a terrible condition to be in. This looked okay, right? This did not look okay, and it evolved into this. And so this person again, probably within a couple of years will be on the transplant list because this is probably going to fail the heart. There's an interesting artifact here. As you can see these edges here, this is a ghost image of this heart. And so this is the direction of the Y phase encoding pulse. And what's happened is there's some kind of every other data point has some kind of phase shift or change on it, and that produces this ghost image at 1/2 of the field of view. So here they are. This is hemorrhagic myocardial infarction. Means that when you do your early gadolinium DTP imaging, you still see a dark spot here. The T2 weighted signal gives you brightness all around that hemorrhagic lesion here. Right? And in the late gadolinium enhancement, you still see this dark signal. Okay, so that's MR beyond, I would say, SPECT and well beyond cardiac CT, and for that matter, echo. Cardiac MRI has the ability to essentially evaluate the health of the tissue itself with many of these pulse sequences. So you can do a contrast injection, and we'll see probably in a later example, if we get there, you can also measure T1 and measure T2 and see how that tissue is doing. So if you've had a heart attack and you want to know, like, how severe was it? What's my next move here? MRI is the way to go. So we're going to move to flow imaging. And this is a really clever use of magnetic field gradients, dynamic magnetic field gradients, to actually encode how fast water molecules are moving in a slice. So remember, if we do a 90-degree pulse, 90-degree pulse here, the magnetization starts in the Z direction, the direction of the magnetic field, winds up in the transverse plane. It has a magnitude in the transverse plane, and it also has a phase angle. So if you measure the angle between the x-axis and the magnetization vector itself, it has this phase angle. The method of flow imaging that we're going to look at actually encodes or changes the phase angle depending on the velocity of the spin. And we'll see in this simple diagram how that works. If I have a phase, I'm going to plot the phase of a spin or a magnetization vector as a function of time along here. My phase angle, we'll say, stays constant in the rotating plane, rotating at this coordinate system called the rotating coordinate system spins at the resonant frequency. So a magnetization vector that is at the resonant frequency in that frame of reference stays perfectly still. It doesn't change its phase over time. So there it is. It's constant over time. And then we switch on a magnetic field gradient in the negative direction. If that spin or magnetization vector is displaced from the origin by some constant distance, it will accumulate phase proportional to that distance and proportional to the amplitude of this gradient. Okay, so here we've got this gradient. The phase here will move, it will actually decrease and go this direction as this gradient is on, right? And then at a certain time, we've moved the phase here. We reverse the polarity of the gradient. So we flip what is positive to negative and what is negative to positive. And now if it has the same amplitude, the phase will catch up. The magnetization vector will be going faster and the phase will catch back up to where it was. So the first gradient pushed it here, the second gradient pushed it back here. And there we have zero phase shift by the end of this bipolar pulse. This is called a balanced bipolar pulse. Then you ask the question, well, what happens if a magnetization vector or a voxel of water, say, is actually moving during the time that we're applying this gradient. So if it's moving in the negative direction, then the phase will basically get subtracted by the negative gradient. However, as it moves along, it moves to lower and lower field values, so the phase accumulation gets slower and slower, or goes in the negative direction, and it peels off in a quadratic way. When you write down the equation for how this works with the v velocity term in there, this phase goes down as a quadratic, right? So it's as t squared when this is a constant gradient. And then what we do is we flip the polarity of the gradient up to positive, and the phase accumulates as a quadratic still because this thing's still moving, and now it's moving up into higher positive fields because we've flipped the gradient. And the accumulation of the phase gets faster and faster and faster. It gets to here by the time we switch the gradient off. So a static spin has come back to its original phase position. This moving spin actually comes back to a position that has a net phase shift from where it started. And that's because it's moving, right? And it turns out this net phase shift here is linearly proportional to the velocity of the magnetization vector. And that's linearly proportional if this is held constant, this is held constant, okay? And it's a bipolar gradient. So if we make an MRI image and we keep the phase information, so every voxel in an MRI image has a magnetization vector, which is represented by its magnitude, brightness, for lack of a better term, its brightness, and the phase shift that it has, right? And so we can make an image that is just phase shift, and that image will be equivalent to velocity times some constant. So here is an example of that where we have a heart. We'll get it beating in a second. We select a plane through here, which we're going to excite. And this is that plane visualized. And instead of plotting the magnitude of the pixels over here, we'll plot their phase. Okay. And so let's turn this movie on. Okay. So here, when the heart's beating, flow is coming through the ascending aorta. And then here's the descending aorta down this way. So this is the ascending aorta is here, descending aorta is here. And we're making a picture every, say, 25 milliseconds or 30 milliseconds. And that picture is the phase of the magnetization. So let's take a look at a couple of examples. When we look right here, okay, the magnetization phase, because this bipolar pulse has been played, is 0 at this, or the phase difference from where it started is 0 here, because this is static tissue, it's not moving, so the phase that accumulates is recovered by the negative lobe of the gradient. If we look at the air in the background, the magnitude of the signal is 0. However, the phase can be anything, right? It's anything from 0 to 360 degrees, right? So it's just a random number generator for phase angle out in the air, right? For those voxels that are moving through the plane, if we put our phase or our velocity encoding gradient, that bipolar pulse, in this direction, right? Then when we plot the phase angle, we can see, oh, it goes positive and negative. So here it goes to a maximum positive signal when it's ejecting blood, like there, bing. And then you can see right afterwards it has a sort of a negative lobe. And so the velocity gets high through the plane, and then immediately goes negative, and then goes back to 0. That's plotting this set of voxels in here. So that looks like that's probably this, which looks like, I'm not sure what the pathology is here, but it's not, it doesn't look normal, right? I'll look that up. So anyway, the velocity through there we can plot. And then if we look down here, this will be something lower down, which is what looks like the descending aorta. So the flow is going in the opposite direction from the ascending aorta. Flow is going into the plane here, it's going at us or out of the plane here. Right? And so there you've got a flow movie by applying that bipolar gradient. In this case, that bipolar gradient was done in the slice direction. So it's just one-dimensional velocity. You can apply 3 gradients, do 3 separate acquisitions, and get velocity vectors, right, where they are in through space. So you can use this to very accurately measure things like the aortic flow. So if I put a slice along here, right, so I'm going to draw it and I'll image my patient along this slice and plot the phase of the magnetization vectors coming out of the aorta. I can then integrate all of those velocities in here to get a amount of blood that is coming out. So the essentially the cardiac output. So you can compute all of these physiological parameters with great precision with this. And so here you can see the beautiful velocity profile in the descending aorta here. Okay. So cine MRI gives you global or regional hypo or akinesis. So when you're just watching the movie, you can see whether or not the heart is beating normally. It can give you all of these precise volumetric calculations. All you have to do is count up the bright pixels a lot of the time, or as we just saw, you can take a flow image and integrate across the area through which the blood is flowing. You'll get stroke volume, ejection fraction, strains, etc. Here, this is an instance of 4D flow, and it means there are 3 spatial dimensions and the time dimension. And so we can watch in this patient who is post-surgical repair of tetralogy of Fallot, we can see the velocity vectors. So the color is the length of the vector, and the little directional arrows are the direction of the vector. And so this is achieved by doing sometimes 4 acquisitions. And you can think of it this way. You do a baseline acquisition with no velocity encoding, and then you do 3 new acquisitions, one where the velocity is in X, one that's in Y, and one that's in Z. And you take the difference between each of those and the baseline, and that gives you essentially the difference in phase from the velocity encoding. That turns out not to be the most efficient way to do that, but it is a way to do it. And after that, you can then have this interactive volume in which you can see where the jets are and what direction all the blood is flowing, etc. Obvious challenge here is that the patient is breathing. And so the heart's going to move up and down, and you need to correct that somehow. You need to track it or correct it. And just the fact that the acquisition takes so long, the state of the patient can change over time, in that when they go in, they might be fine with a pretty constant heartbeat of 61. And then by the time you're done, they're, quite anxious and their heartbeat's 78 or something like that. So just how stable the patient is over time is also a factor as to how this turns out. Okay. I think I'm going to pop out of this. Oh, so this is showing in the 4D image, you can draw a line or a plane through any orifice or pathway you want, and then integrate how much flow is going through that shunt or orifice. Okay. Yeah, I think we're going to go to a different slideshow at this point. Okay. All right. So going back to our use of T1 and T2 imaging, just a quick review of what T1 is. It's the recovery. So if our magnetization starts out along the direction of the static magnetic field, and we apply a 90-degree pulse, so the magnetization goes in the transverse plane, it recovers back towards its equilibrium value m naught with this time constant T1. So this is it's a first order differential equation, just like the way hot tea in a cup moves towards the ambient temperature of the room. It's the same kind of model. T2, recall, is the rate at which the transverse magnetization dephases in the transverse plane. So it's that reduction in signal when you first apply that 90-degree RF pulse. So all of these time constants now are measurable. And the reason is the speed with which magnetic resonance scanners work has increased because the gradient switching has increased so much. And the coils have become so much better that the signal to noise has increased such that you can potentially measure these time constants. And as I said, early on in MRI, we all thought we'd be measuring these time constants every day. And that turned out to be harder than it was worth, right? It was better to spend your time averaging an image that was proportional to T1 or T2, but wasn't what you needed to invert the signal to get the actual value. But that's changed now. So this is the whole suite of sort of contrasts that are now available if you're trying to evaluate myocardial tissue, right? So we can measure the actual T1 value of each voxel. Say, what is the recovery? And you can see in this patient, there seems to be a higher T1 value, perhaps here. The actual T2 value in each voxel of the heart. T2 star, which is the T2 value without that spin echo. It's the value of the initial decay of that signal after the 90-degree pulse. You can compute things like extracellular volume fraction. And so looking at a change, so here you can see the extracellular volume fraction in this tissue here has shot up. And so that is equivalent to this amount of fluid that's outside the cell. And it's a way to really quantify the amount of swelling of that tissue or edema. You can evaluate, because fat atoms, basically the hydrogen in fat resonates at a slightly different frequency than the hydrogen in water. You can isolate the fat and the water signals when you're doing proton NMR. And here you've got some buildup of fat in the tissue, right? So which is essentially a specific disease. We have late gadolinium enhancement here, where, as we saw, it gets bright in infarcted tissue. Early gadolinium enhancement here, showing that there's a lack of blood flow or a lack of perfusion. So this is competing directly with something like SPECT to do perfusion imaging. And then, you can just see that there's a dark spot here, and that's fine. I mean, it's pretty diagnostic just in its own right. But if you acquire a number of these in a baseline and you get them over time, you can actually calculate quantitative perfusion, much like we saw in PET, where you can get milliliters of blood per gram per minute in the heart. So all of this is now available if you're very careful on how you image the heart. So again, magnetization, when we start at an equilibrium value, if we do a 180-degree pulse and we invert that magnetization to here, depending on its T1 time, let's go to this time here. At this time, if we take an image with this delay after this 180-degree pulse, the signal I get from cerebral spinal fluid will be 0. I just won't see a signal, will be dark. Normal brain tissue, I'll have a certain brightness, and then fat, I'll have a brighter signal because of the T1 constant. So if we look at native T1 maps, and they're called native because we haven't injected any contrast into this patient. So the question is, like, can you make some kind of diagnostic call in a patient if you don't have to inject a contrast agent? So that would be pretty cool. And so here, if we do one of these T1 maps, we'll see look at a pulse sequence where we can do this. And we have a really stable value of T1 at all points in the myocardium for this patient. So down here at, like, I don't know, 850 milliseconds is the T1 throughout the myocardium in this normal patient. And then we can see in this patient who is suffering from acute myocarditis, that's kind of like an infection, the T1 of a section of tissue has gone up considerably. And so it shows itself just in the T1 contrast or in the T1 value. And here, cardiac amyloidosis, same thing. We get an elevated T1 throughout the myocardium. And so it's now been established with these new T1 methods that you can do diagnostic imaging without injecting a contrast agent. So if we look at what happens to tissue post-MI, so someone has a heart attack, we've seen a couple of cases where we saw changes in MRI as a function of time after a heart attack. And so here we have a number of different types of tissue. We have an acute event, flow gets dropped in this region. If we jump in an ambulance and get to the hospital in time and they open up this thing, right, and they put a stent in there and keep it open, you'll salvage the tissue, right? So the whole thing will just come back to life. If, on the other hand, it takes you multiple hours to get into the cath lab, you'll probably salvage the penumbra of this thing, but you'll lose a central zone. And then here, if you just shake it off and don't go to the hospital, the tissue dies and you get an infarct, like a solid necrotic core there. Doesn't kill you right then, but it is dangerous in that it can act as the nidus for abnormal electrical activation. And it can lead to heart failure for that matter. So let's see how you would measure T1 in a heart. Well, if we have a lot of time and the patient can hold their breath and they're basically very stable, we can do it like this. We can apply a 180-degree pulse such that the magnetization starts at -1, and then we image at some time delay after that 180-degree pulse. Here, it's a very short time delay. So when we take the image, because everything has a large magnitude, it looks like this. We haven't reconstructed this image with the phase intact because it turns out the magnetization vectors here are in the opposite direction of these ones. They actually have a 180-degree phase shift on them. But for the most part, magnitude reconstruction is used in MRI, and so this image shows up like this. In this case, if we take a 180-degree pulse and then we wait, this looks like we're waiting about 1,100 milliseconds, right? So it's almost a second. And then this tissue here, which is the blood, is crossing zero at that time. So it's recovering with T1 recovery. It's about to cross zero. We make an image right here, and we get zero signal from the blood. We get a slightly positive signal from the myocardium. And then we acquire an image out here. This is above 2 seconds, and we get these two contrasts. So now we've got, for each voxel, we can plot this curve, right? And then you just fit it and you solve for the T1 value and then produce that as the T1 picture. And so here's our T1 map for the 5 images we've taken. We run a fit and we can plot it as a T1 map. Okay. The problem with this method, obviously, is that it just takes too long, right? So this is a second. This is 2 seconds, 3 seconds, 4. So we've got to do a 180-degree pulse and then wait 3 seconds and then acquire. So we've got to do that for every phase encode step for MRI. And so if you're doing 128 phase encode steps, it's a lot of time, right? So it isn't really tenable when you do it that way. What's changed in the last few years is these saturation recovery with a single shot acquisition. And so that means we're going to go get a whole bunch of data really quickly. And this whole thing gets done in, seconds, right? And we acquire a T1 recovery curve. It has a slightly different recovery curve than what we saw with the inversion pulse, but we can still fit these data, right, to a T1 recovery curve and make a T1 map. So what's done is we produce a essentially 180-degree pulse and then do rapid pulses that increase the delay in our QRS intervals so that we sample these different recovery points on the curve, right? So we have an early recovery point and a later recovery point on this curve. The curve is very quick, right? But it's enough of a T1 recovery curve to get these differential amounts of recovery depending on what our delay is between the excitation pulse and when we make the picture, okay? And we're going to do that in one sweep. So we get a whole set of pictures like this. They fit into this curve, and then you get a T1 map. Another method is called the look-locker inversion recovery method. And it gives a slightly larger dynamic range of values that we can fit for T1. But it's essentially how you model the signal that you acquire at each time in the QRS and the delays between acquisitions such that the whole tissue has the ability to recover to a new part of the T1 recovery curve. And so we get a whole sequence of these pictures very rapidly that can be fit to this model here. Again, it makes a T1 map. If you do these carefully, you can then use these T1 maps for those diagnostic cases that I was showing earlier. Okay, you can read this later. These are, or if you're interested, go to the original papers for how they've sped this T1 measurement up. Sampling, we still have breath hold duration as a limitation. For all MR in which you're doing precise voxel fitting, you'd like the voxels to be in the same location. And so it's usually done with breath hold. Because it's single shot, that means we're doing a lot of K-space in a short period of time, which means we're something has to give, right? We can't get out to the high resolution regions of K-space And so the images look a little bit blurry. Okay. So here's examples of images when a patient is breathing during the injection. Okay. And so this is a contrast injection, and this patient is breathing. It's fairly obvious that over the course of this injection, which is like 25 images over 45 heartbeats, so you can't really ask a patient to hold their breath for 45 heartbeats, but you suffer for not having them hold their breath. And you can see why SPECT imaging looks like a really blurry donut. Part of that reason is because this thing is bouncing up and down, on the order of 1 to 2 centimeters, right, during breathing, which is going to blur your signal tremendously. You can, if I mean, those of you who are looking at this, you would just say, well, you know what? I can see this is a coherent picture of the same object every time. So I can just like map one heart onto the next time frame. Just pick a time frame and map everybody back onto that time frame. And that can be done. And it's done pretty successfully. So here, the issue with MR is usually you're imaging a single slice, right, for these rapid acquisitions. And as we saw in the movie of this heart moving, right, that if my slice is here, right, the myocardium that I'm imaging is coming in and out of the plane, right? So unless I can do a three-dimensional re-registration of this tissue, if all I'm doing is imaging a slice that's perpendicular here, right, like this one, that piece of myocardium not only is going back and forth this way, it's coming in and out of the plane. It's a different piece of myocardium, right? So if in MR, we're doing these quantitative imaging sequences in one single plane, you look at the essentially one of the segmentations of the myocardium and then map that segmentation on other views, and then the heart just doesn't overlap everywhere. So it makes it a challenge. You really ideally would like to do this stuff in 3D and then do a 3D re-registration of all this stuff. This is, as we've seen these before, this is, if you hold your breath, you get these amazing, movies of, let me show why it's not. Yep. Tell you what, Microsoft and Apple stopped playing together very well on movies in your show, and it's really screwing us up. Okay. One day they'll get it back together, I guess. So again, you don't see any respiratory motion. This image was taken in 12 heartbeats, and so you get this great clarity. However, you still have the issue that if I wanted to do a short axis slice through here, or let's say up here, if I look at just where my voxel in space is constant, is on that little arrow here, you can see how much tissue is moving through that point, right? So if I say, oh, I'll do my analysis here, tissue is moving through that point. So this is the through plane problem of measuring things in MRI, because all these images are beautiful, but they're all 2D, right? So we're not doing that through plane thing very well. If we want to essentially measure, we've looked at this before, if you want to measure motion really precisely, you can put markers in the tissue by applying what's called a pre-saturation pulse that knocks out the signal in parallel planes. And then if we do that here, we can see that where it goes to at some time later. So if we look at this line, and you ask the question, well, what do you know about all of the magnetization vectors in voxels along that line? You know where they came from in this direction, right? They were in a parallel plane down here. You know all of these were in that plane. You don't know where they were in and out of the imaging plane, right? Because we haven't encoded that. But what we've encoded is what is their displacement in the vertical direction. So you can encode in those three directions, vertical, left, right, and then through the plane, and come up with a model of how the 3D displacement is occurring. And so here you can continuously take pictures over the heart cycle and get dynamic strain maps. And that you can do that in it's super high resolution if you correct. Here we're gating to the ventilator, and we're gating to the ECG. And so we're getting these amazingly high resolution pictures. So how do you do that encoding? So here's 9 slices through the heart. Each one of these slices was taken individually. Here's a slice in the middle, right? And we've encoded left-right displacement with these lines. So you just get a segmentation program to go through here, pick out all the voxels that are along these lines and map those into space. Okay. And we have the left-right displacement. That's what this information gives us. We've taken the exact same image or slice for this image, and this encodes the up-down displacement of all of these voxels. They're different than these ones, right? But it gives you a field of displacement values for the up-down direction. You get a field of displacement values for the left-right direction. The points aren't the same point that you're measuring, right? And then to get the displacement in and out of the plane here, we look at 9 different long axis views, and they just like a clock. We go around the long axis and measure how the displacement is going up and down through the slices. So you get 3 independent measurements of displacement. You put those together in a least squares way to get the best displacement field for 3D motion, right? And you can now map that 3D displacement field as a color, say, in different parts of the myocardium. You have it all throughout the myocardium. Okay? And just as a couple of examples of how precisely you can actually measure myocardial tissue motion, here is a left ventricle right at the onset of contraction. So right as the QRS is going off. And this is only 40 milliseconds later. You can see that there's essentially the yellow is encoding the radial strain, which means how much have these lines expanded in the radial direction. So here's the center, that's the radial direction. How much have they expanded at this point? Well, they've gone up by 15% right here. The blue means this is 0. The blue means they have been compressed. So these 2 lines are closer together. These 2 lines are farther apart. And so that means you've resolved the actual propagation of strain from the epicardial side of the muscle here to the endocardium, right? And this is being compressed. So the thing on the outside is pushing and it's compressing that inner one, because this one probably hasn't actually been activated yet. These cells probably haven't depolarized, right? And so that's the kind of resolution that you can achieve for strain with MR. Nothing else gets close to this, right? So echo or nuclear medicine or whatever. CT can get very close to this where you have physical boundaries and features that you can track, such as the endocardium, and we saw that in the CT applications, right? We had all of the trabecular tissue like crushing down, and you could track all that stuff. But that's just on the endocardium. CT can't help you out. It's sort of in the middle here because everything is that same myocardial gray, right? It's like 60 Hounsfield units, and there's nothing to track, right? Early on, actually at UCSD, some pioneering um, cardiac physiologists put these little tantalum screws into the myocardium, and then they would use biplane x-rays to watch where those screws went. And so they look at the distance, say you have 3 screws, and you look at the relative distance between all 3, and you can calculate the strain in that box. And they actually did it in patients who were undergoing heart transplants. They actually put the tantalum screws into the heart that they got, right? And I'd love to, love to see the IRB on that one. But anyway, what they showed was that preceding all of the metabolic and blood tests for whether or not you were having graft versus host disease, the strain actually changed first, right? You lost a certain amount of twist on the left ventricle very early on when somebody was going to go into this rejection phase. And so measuring strain makes sense for many things, for whether or not somebody's going into heart failure, whether or not the ischemia has resulted in a change in the myocardial strain, etc. This is an example of how strain that you measure with this, with this type of tagging technique, we can measure the circumferential strain as a function of time. So here's 1 second. This is the amount of circumferential strain. 0 means nothing changes. It's an original condition. Negative means things get shorter. Okay, so if I have a line, negative 15% means it got shorter by 15% going this way. And if we look at what we've got in the heart, so I have a hoop around here, right? So there's a length of a line that's along that circle. And then when the heart contracts, that hoop gets shorter. So it becomes a smaller hoop. That's circumferential shortening. You can measure that with very precise localization with tagging, right? So all I have to do is look at this box and say, what does that square turn into over here? It turns into some kind of, trapezoid, and I calculate the strain inside there, and it gives me the strain in this direction. I have the strain in all directions actually, but it gives me a little tensor that tells me what the strain is in this direction. So I can measure circumferential shortening. This is in a normal person. Okay, so normally when I say normal person, that's one of the grad students jumped in the magnet. The great thing about MR is you just jump in the magnet, right? There's nothing to stop you. And in fact, we had a magnet at the NIH that was a short experimental magnet that's no longer on sale, but I love that thing. And it was a 1.5 Tesla magnet, really short. And they had a special keyboard that you could bring in the room because we were going to use it for interventional stuff. But I could run experiments on myself and control the scanner, like lie on the scanner table and enter new parameters and take a picture and enter new parameters, take a picture, which was really great. So here we see there's a rate at which the circumferential direction shrinks down as the heart's contracting. So this is a diastole, or the beginning of contraction. This is asystole, when the chamber is at its smallest volume. And so the muscle is contracted down to its smallest length. And here we've hit sort of like about 17% contraction. And it remains there for about 50 milliseconds or so at this end systolic condition. And then boom, it pops open. And it pops open faster. The strain rate here is faster than it was on the contraction side. Okay, so the muscle relaxes, and it basically sucks blood in through the mitral valve. And then it sits in this condition for some time. This is diastasis. So your heart's just filled with blood, and now it's just resting there, right? And usually when your heart rate increases, this is the thing that changes the most. You can add time in this to slow your heart down, and the heart contraction mechanics looks similar. You've just slowed your heart down by changing this duration. And then when your heart speeds up, you can just like cut this duration down. And then the mechanics doesn't necessarily change, but the duration of diastasis does. In patients who, and we had, I want to say about 20 patients, 25 patients or something. You can go look it up. This is a PhD student in my lab. These patients had hypertrophic cardiomyopathy of varying degrees, and a couple of observations. One, the rate at which their shortening is occurring didn't really change. I mean, this slope and this slope looked about the same. However, this cut off more quickly. So they only got down to about 10%, say at mid-wall, my circumferential shortening. But what really changed was when the heart relaxed, it slowly and viscously it just slowly filled up, right? So there was almost like there was some kind of internal friction that was holding the heart together. It wasn't allowing it to pop open the way it did here, right? And so the difference between this slope and this slope was the big parameter that essentially predicted who had hypertrophic cardiomyopathy. It was quite a difference between the normals and the hypertrophs there. So that's how strain and strain rate can be used as diagnostic parameters. You can make very interesting strain maps if you're doing this and you have the precision and the spatial resolution to make a strain map in which you see the local strain events in the heart. And so let's look at this first. This one's an interesting one. This is time going from left to right. So this is end diastole. This would be end systole. So when the heart is maximally contracted. This point here, that's the location of a pacing lead that is in the right ventricle and is stuck onto the essentially the septum side. So it's inside the right ventricle, stuck to the septum. And at this time, the heart has been paced, and this blue color is the shortening. What we're mapping here as a color is the myocardial shortening at that local location, so the circumferential shortening. So you can see there's a volume around that pacing lead at which that shortening has begun to occur. It hasn't begun over here. We don't see it over here, right? This side nothing has happened yet. Say 60, 100 milliseconds later, the strain has expanded out to the whole septum, and it's crushing down now. And on the opposite wall of the heart, the myocardium is actually being stretched. It's paradoxically going in the wrong direction. So instead of contracting, it's expanding out, right? And that's what the yellow color means. It is the circumferential strain has gone positive. At some later time, it gets activated and it does participate in the contraction like the septal side did. However, it's late. And so it's called a desynchronous contraction. And what this is simulating right here is basically a left bundle. And that means that when you have a left bundle branch block, the Purkinje system on the left side of your heart has been blocked off by, say, an infarct or something, killed the tissue along that pathway. And so the activation isn't going normally through the Purkinje system to the left side. So the left side is delayed. the activation moves through the myocardium instead of the Purkinje cells. So that's a classic left bundle. However, we made this by having a pacing lead here. If we turn this pacing lead off and we turn this one on, so this one's on the LV or the base of the free wall of the LV, we get essentially the same behavior. It's just the origin of the strain is now at this pacemaker, right, or this pacing lead. And so you can see it early contraction, nothing going on over here. And then as the contraction moves to different parts of the heart, we see a bulge on the septum. So the septum goes backwards, and then the septum contracts late. Okay, so that's that desynchrony. We can have fun by turning them both on at the same time, right? And then we see the contraction start here and here, and then it's a synchronous contraction that comes in. And this synchronous contraction looks somewhat similar to the contraction you achieve with just normal right atrial activation through the Purkinje system. So you get uniform activation of the ventricle. This biventricular pacing is called CRT, or cardiac resynchronization therapy. And that's for patients who naturally have this going on without providing it with a pacing lead. Just their heart is contracting early on the septal side. And so what we do is we put a lead up here and turn this into this, right? And so that the mechanism by which all of that occurred and mapping the rates at which the mechanics went around was all measured with myocardial tagging when cardiac resynchronization therapy was under its development. Okay, so that's strain. And so we'll go back now and look at some curves of myocardial perfusion as we see them in MR. And we can make a baseline image or a proton density weighted or baseline image where we inject contrast at this point and we see it come in to the right ventricle here. So the right ventricle is very bright and it goes out, right, the pulmonary artery to the lungs, and then it comes back from the lungs into the left ventricle, which gets bright after this. And then as it comes into the left ventricle, it also goes down the coronaries and into the myocardium. And so we see the uptick of the signal in the muscle itself. And then we can look at the shape of these various, like this various input function, or instead of using this, I think the input function is fine to use the left ventricle for the myocardium because it's just goes out the aorta and then down the coronaries. And so the timing of how the coronaries are being fed is essentially this curve here is the left ventricular curve. So you have the input function, we have the response of the tissue here, and with those parameters, you can measure an actual quantitative flow map, just like we could in PET, and where we get milliliters of blood per minute per gram. And you look for these regions in which that blood flow is low. As we have seen before, this is what perfusion imaging looks like. You see the left ventricle light up, and then the contrast flow away, and we look at the signal in the myocardium. This is CT because it's such a beautiful illustration of how much motion we're getting. You need to apply that registration, and we can do it in 3D. On CT, we can do it fantastically well because all of these features are very clean. You can do this with MR as well. And so now you see the heart basically is in the same position for every one of those 25 time frames. The images themselves had to be distorted by some basically not just a rigid, it's like a non-rigid deformation to try and put everything, map everything on top of everything else. And you can see sometimes the spine gets completely moved away because it's not in the control zone. We really don't care if we do this the spine. So what we really care about is this part right here. Is this heart always going to look the same? And this is now done on all perfusion cases fairly successfully. And so that this is what the perfusion then looks like after the correction is done. Excuse me. So this is a really cool example of MRI used as a guiding imaging modality for applying therapy. In this case, we have a normal left ventricle, right ventricle. In there, we have put an electrode, actually, and the electrode is measuring the myocardial voltage, the peak amplitude here, which is 7.3 millivolts. And so you can go point by point in the myocardium and see the depolarization locally, like the size of the darn electrode, right? What's done here is this is the same measurement. Here, our peak amplitude has been cut in half, and the tissue looks bright, right? And so this is post-application of radiofrequency ablation therapy. And so radiofrequency ablation is used to kill tissue that is causing arrhythmic behavior of the heart. So if you are in AFib, or heaven forbid, you have really long bouts of ventricular arrhythmia, the clinician will go in under fluoroscopic guidance, usually with a CT on the computer, and then they'll map your electrical activation with these electrodes and find the nidus of the abnormal behavior and then put an RF electrode there and burn it. And so you put it up to 47 degrees for a couple of minutes, and that tissue essentially gets burnt or dies. And then ideally, the abnormal electrical activity goes away. This is, in situ imaging of what that burn looks like. So post-burn, so about 5 minutes after the 2-minute ablation was applied, contrast, a little shot of contrast was put in, and you could see where that burn had affected the tissue, right? So it gives you an ability to know whether or not you have actually achieved a burn over the space that you're interested in, and you haven't left any of the abnormal tissue behind. So we thought it was an exceptionally promising technology. We worked on it for many years. However, it really didn't take off commercially. It's a big research topic, but commercially, putting MRI scanners into cardiology departments and asking cardiologists to do MRI-guided electrophysiology, it was only for the upper elite EP docs, who really wanted to go to the trouble of doing that. And it was expensive. All the equipment had to be magnet compatible, RF compatible, all of this stuff. So it's a really high bar to get in there. And so it really didn't take off commercially. But from a research standpoint, all the major, Harvard and Hopkins, we had 2 labs at the NIH and things like that. And so it showed really great promise, but a little tough to get into actually for your average clinician. We looked at that. But what I wanted to show you was if you can image this infarct. And so you make a really nice picture of it. And we tried for years to make super high resolution pictures of these things, but we couldn't get the heart to stay in the same position at sort of 0.5 millimeter resolution. So you hit a limit to the resolution. But anyway, if you can image this so you know where the infarct is on the heart. A colleague at Hopkins, Natalia Trianova, we did this maybe 15 years ago, maybe more, but since then she's commercialized this and it has a really cool product that will help clinicians determine whether or not a patient is at high risk for generating a lethal arrhythmia. And let me see if I can run it. Okay, here we go. You know what? I'm going to bounce out. Can't bounce out. So here you see we imaged this infarct to this kind of spatial resolution. And then she runs a computer-generated, there we go, pre-ablation. She runs a computer-generated activation map around that infarct. So here we're activating the heart at the apex, and then these waves of activation are going through, and then this is a self-contained, essentially, loop of activation in which the activation wavefront comes out and chases its tail back into and through the infarct. What happens is that as you can see from the activation slows down as it goes through the infarct, right? And so it gets farther and farther behind. And then at a certain pacing rate, it will catch. As it emerges from the infarct, it catches on itself and gets into a stable ventricular rhythm. What you can do then is say, okay, if we ablate this infarct, if I see my infarct here, what we're going to do is we're going to go in here with an RF coil, ablate this entire region. Okay, so that doesn't have any conduction at all, right? And let's see if that can stop the initiation of this, essentially, trigger of this arrhythmia. So post-ablation, this is what it looks like. So now you have the infarct completely removed because we've ablated it. And under those same conditions to try and induce an arrhythmia, it's impossible to induce that arrhythmia. So this heart is more stable than it was prior to the ablation. And so this is now a commercial product. But ideally, what happens is you do a super high resolution late gadolinium enhancement movie. Natalia and her group put it into their simulator and say, like, how probable is it that you will generate a self-sustained ventricular arrhythmia? And then if it is probable, you can go to the cath lab and have it ablated. The other thing we did in interventions was we created these needles, right, that you could see under MR guidance. And so essentially this is a classic, it's called a stiletto catheter. And it was just a clinical catheter, right? And it was made by Boston Scientific. What we did was we put some coils all the way down the stiletto catheter. So one wire that was activated all the way down through it, and then a couple of loop coils at different locations. So we could see these things on MRI. And so this is what it looked like on MRI. We see the coil itself, this wire, and we see the tip, where the tip is, because it's got a different coil. So the MR signal is going through those coils, and you just map it back to the image as a color, right? And so you can see where that coil is. Not only that, in real time, when you inject something, you can actually see where the injectate goes into the tissue. And so here's an injection of gadolinium showing the volume over which that injection is occurring. And so we did this to inject stem cells around infarcts. Turns out they didn't really turn into normal myocardium, unfortunately. But this is also can be done to inject, say, different agents to kill tumors, to also ablate tissue, things like that. And you can do it with high accuracy. You can put these needles in and inject. The heart technologically is really hard to do this in the heart. Obviously, it's easier to do it in, say, the liver, where you have a tumor or some other tissue that you want to ablate, and then it pretty well stays, in its location, and then you can move this in and see where all the injectate goes. It's a pretty cool application. And then here, this is the last heroic application I'll show you in cardiology, where we have a trocar that we have essentially inserted into the apex of this heart, right? And this is under real-time MRI guidance. We've got the plane to where we want to see, and now we're going to take a device which happens to be an aortic valve, and we're going to push the aortic valve under real-time MR guidance into the native aorta here. And so the clinician, this is a cardiac surgeon, I did this with Keith Horvath, he's pushing that in and maneuvering it to get it right into the right spot. And then he's going to inject fluid into the balloon that is on the interior of this valve. And then that fluid is going to inflate the valve and essentially lock it in place to replace the damaged aorta that's there. And so this is called TAVI now, in which you have aortic valve in humans that comes up and around and is deployed into their valve. And CT is usually used to figure out what size you want and everything like that. But this is doing it under real-time guidance. And then we've left the valve in, we pull back the rest of the hardware, and then you can do in place, you can just do 4D flow to make sure the flow is coming through the valve okay and make sure that there aren't leaks on the side, etc. Again, fantastic application, but it's a reach to try and get this into just your everyday cardiology cath lab. Again, it's like in a dozen cath labs around the world, but they're all at the top institutions with really exceptional cardiologists running them. Okay, so I'm going to stop there. That's a whole suite of applications that I've been interested in over the years. That's why they were picked. And next week, like we'll start right on the dot of 9:30 on Monday, because we have to get through half of the projects. So 10 minutes per project. So if you can come in at 9 minutes or 8 minutes, use 8 slides is what I would say. That keeps your time. And also rehearse so that you know you can get in under the 9 minutes. That gives us about a minute for questions, etc. Okay, and we'll do it on both Monday and Wednesday. If you need some help between now and then, don't hesitate to email, and we'll try and get you through any or modify your project so that the thing that's blocking your progress, you can just go around it somehow. Okay. Oh, the other thing is, I believe you'll get a questionnaire about the course, sort of an evaluation questionnaire. It's important to faculty at this university that those questionnaires get filled out so that their teaching is evaluated by the students. Okay, so they take it seriously here. It would be great if you could fill those out. And it's been a good year, so we'll see you on Monday.